So may I invite Dr. N.C. Ambekar, Dr. Vaibhav Keskar, Dr. Manish Mali, and Dr. Ankit Modi. And the speaker for the next session is Dr. Philip Kalra, who is a professor of nephrology from the University of Manchester. And he's been a part of a lot of trials which have been conducted in the UK over the Astral and the Pivotal and the Ironman trials. And we'll hear from him his opinion about iron correction in one visit. Is it feasible?
Right, thank you very much indeed. Thank you very much for the introduction. It's a real pleasure to be here. I'd like to thank Zydus and Pharmacosmos for bringing me over to India. I'm going to just show you this picture to start with because it highlights my link to India in many ways. So on the left is my current hospital, but on the right is how it used to look about 30 years ago. And I actually grew up in a hospital grounds a bit like that because my dad was a consultant psychiatrist who came from India. He was from the Punjab. He came over after the Second World War and trained in the UK. But anyway, there's my link. That's where Kalra is from, as I'm sure you will have worked out. So this is the outline of my talk. I'm going to briefly talk about the epidemiology of anemia, safety concerns with intravenous iron, short and long term. I'll emphasize phosphate and hormonal perturbations with IV iron therapy, tell you about the rationale for high-dose iron regimes. You've heard that already from Dr. Kuller before, and give some personal experience of using monoferric as well. And if there's time, I'll just tell you very quickly about the Ironman trial, which obviously involved monoferric, that was published in The Lancet in November. So prevalence of anemia in CKD in India. You'll see to the left here, we have CKD stages 1 and 2. So clearly these patients are not anemic because of EPO deficiency with GFRs of greater than 60 mils a minute. Likely to be iron deficiency for the majority of them, but as we go through the stages of CKD, we're well aware that by the time we get to stage 5, we can see at least 50% of patients who have got anemia, and when we get onto dialysis, of course, we've got 98 to 99% of patients who are anemic, and the cause of the anemia is multifactorial, isn't it, involving inflammation, reduced EPO, iron deficiency, and of course things like advanced hyperparathyroidism. I like this particular slide because it shows that in our body typically we would have 4 grams of iron, about 1 gram of that in the liver, 1.8 grams in our circulating red cells. I'd like to point out a couple of things, though, that are really important. Number one, note that our average intake is tiny. We take about 20 milligrams of iron in orally per day, but only about 10% of that is absorbed, so we actually take 2 milligrams into the circulation. And in the person in balance, we lose 2 milligrams a day. The second thing is transferrin. It's only a small amount of iron within that, just 3 milligrams, a tiny amount in the TSAT, if you like. And finally, I just want to point out this, really importantly. Remember that there is iron in every cell of the body. It's really important in our electron transport chain for the development of ATP. And that's why you often see patients who are not anemic but iron deficient who feel so much better after having been given iron replenishment because of their energy stores. So let's talk a little bit about the safety of intravenous iron. I really think it's helpful to all of us to break this down into 3 areas. Immediate reactions, medium term and longer term. So in terms of immediate reactions, we recognize 2 main areas. There's hypersensitivity and of course anaphylaxis, as we heard earlier, with the modern intravenous iron products is very, very rare indeed. We're looking at maybe 1 case per 200,000 to 1 million. So it's very rare. We do see mild hypersensitivity, but more commonly, we see what we call labile or non-transferrin bound iron reactions, which is associated with the fairly rapid release of free iron into the circulation. And I'll tell you more about that in a few minutes. Medium-term reactions would be hypophosphatemia. Again, I'm going to spend some time on that. In terms of longer-term problems. We talk about infection risk, and this has been borne out of the laboratory really, because there's evidence that in the Petri dish, when you bathe immune cells, T cells, and phagocytes in high concentrations of iron, they don't work as well. Phagocytes in terms of literally phagocytosing or migrating, and T cells in terms of their cytokine release and calling other cells. So there's a theoretical risk there. And what about the cardiovascular risk? Well, that comes about because of, in fact, have we missed a slide? Anyway, this comes about because of the so-called Fenton reaction, where reducing iron from ferric iron down to ferrous iron leads to hydroxyl radicals, which theoretically at least can damage vascular endothelial membranes. And if you get repeated dosing leading to repeated oxidative stress, there is the theoretical risk of cardiovascular events, atherosclerosis, of course. So this slide is 20 years old, well, at least the data is from 20 years ago, and it purports to show that we recognize that different iron preparations are associated with different risk. In deep blue, you can see the old-fashioned high molecular weight iron dextrans, which were well known to have a high reaction rate for serious life-threatening allergy, life-threatening AEs, as you can see. Whereas to the right, we see iron sucrose that we now use a lot of in our hemodialysis patients, don't we? Which has a much lower risk. And this is data from 30 million dosings of intravenous iron collected by Glenn Chertow, published in 2006. Concerns about cardiovascular infection risk have been stimulated by studies like this. This is DOPS, you'll be familiar with this, so this stands for the Dialysis Outcome Practice Patterns. And here we compare patterns in dialysis in different countries. And so this is the European DOPS. Within this, the UK contributes, so too does Germany, France, and Italy. And you'll see to the right of this figure that patients on hemodialysis who are receiving more than 300, 400 milligrams of iron per month on average, so we're talking 5 grams plus per year, seemingly were at increased risk of cardiovascular mortality, all-cause mortality, and a signal towards infection-related mortality, causing a big worry for us, really, compared to what we would consider as a typical dosing regime, which might be 100 to 200 milligrams per month of iron. That would be the typical dosing that we see in the UK, and I'm sure it would be very, very similar here in India. And I've mentioned the Fenton reaction already and the oxidative stress. One thing to just demonstrate here is that when we're looking at iron structure, it's really, really important in considering the nature of reactions. So to the left, we see, again, the old-fashioned high molecular weight iron dextran, which had a structure with an iron core, a large iron core with a thick carbohydrate shell. Now the shell had many branch chains with the potential for causing allergy, okay? And also with this iron core, once the molecule gets into the circulation and breaks down, there can be a rapid release of iron into the circulation, hence this non-transferrin bound iron reactions. However, to the right, we see the structure of monoferric, which is more of a matrix with iron represented throughout the molecule. And so when this molecule gets into the circulation, there is a gradual release of free iron into the circulation. The other point is that the sugar chains in iron isomaltoside are very short, only about 1,000 Daltons. They are not branched, and hence the potential to cause serious allergy is also markedly reduced. And this is demonstrated in this slide here. So this is the release of non-transferrin bound iron, free iron, into the circulation. Notice that the fastest shown here is with iron sucrose in green, very rapid, and iron isomaltosode or monoferric, has the slowest release, and it has a very low peak. In red, we see ferric carboxymaltose. I'd like to point out here that we must be aware of generic compounds of iron isomaltoside, because they're probably going to behave very similar to the iron sucrose here in terms of the release of free iron, because the structure is not the same as monoferric. Now, when we're talking about reactions, we've got to be aware, and our staff have to be aware of the likely time course. So, though I've said that the risk of anaphylaxis is extremely rare, we would always need to be aware of the possibility that it could occur. And our staff need to be trained, don't they? So if someone is going to have an allergy, if they're going to have a labile iron reaction, it is likely to occur in the initial stages of the infusion, certainly in the first 10 minutes or so, or during the infusion. It's unlikely to occur afterwards. To the right, you can see what's called the Fishbane reaction, which is very common. We see this in my practice in maybe 1 to 2% of infusions. And this is not a serious reaction. It leads to flushing. It's due to, we think, non-transferrin bound iron, or maybe a pseudo-allergy. And you see flushing. The patient might complain of slight left shoulder tip pain and maybe some upper abdominal pain. The key management is to reassure the staff, reassure the patient and yourself, stop the infusion, and inevitably in about 10 minutes it's possible to restart the infusion at a slower rate, and the patient will be able to accept the iron. And next time that they have an infusion, you'd be able to maybe just start a bit slower, but almost always they'll be able to tolerate this. So I just wanted to show the importance of clarifying the nature of a reaction. This, believe it or not, was genuinely the first case in my hospital who received monoferric. It was one of my patients as well. She was a 35-year-old with focal segmental glomerulosclerosis. She was on EPO, and you can see the parameters there. The key point is that 5 minutes into the infusion of monoferric, she developed dyspnea, left shoulder pain, and a tiny drop in blood pressure. She was very anxious. The staff were anxious. The junior doctor was called. The infusion was stopped. She was given prednisolone. She was given chlorpheniramine. And she was sent home 2 hours later when she recovered, but she was labelled as allergic to intravenous iron. Now, if we actually attach the label allergy to someone who's had iron, then nowadays we should not give them any further iron preparation, even if it's a different iron in the future. That would be our recommendation. Just like if someone has a penicillin allergy, we would not give another form of penicillin. Anyway, I saw this patient in clinic 2 months later, went through the history, and it was pretty clear to me that this was a labile iron reaction, and we brought her back, and she has subsequently had 5 further iron infusions, and I heard actually, and safely, without any reaction, and I heard actually 2 days ago, whilst I've been in India, that she had actually had a kidney transplant after quite a long time, which is very pleasing. So we can be reassured with some data, especially RCT data, about the safety of intravenous ions. You may be familiar with this paper from Avni, which was published in the Mayo Clinic Proceedings about 8 years ago, where they looked at over 100 RCTs where intravenous iron was involved versus a comparator. The comparators varied from placebo, no iron, oral iron, or some unlucky patients got intramuscular iron, 155 of them. But you can see that overall, in the 21,000 patients, that it was really a null result. Sorry, just get the pointer here. You can see that the relative risk was 1 for serious adverse events in this huge study, this huge meta-analysis. You heard from the previous speaker about the pivotal trial, so I was one of the organisers of this with my colleague Ian McDougall, and this is a study conducted only in the UK, and it came about because of what we heard before, because of studies such as TREAT, which was published in 2009, 4,000 patients, not all diabetic, non-dialysis CKD, and demonstrating that with high doses of EPO, trying to push higher hemoglobins, there was an increased risk of stroke and recurrent malignancy, remember that? And as a result, particularly in the United States, there's been a push with bundling to increase ferritin levels. So in the United States, you might typically see ferritins of 900 to 1,000 micrograms per litre in the patients in an attempt to reduce ESA doses. So Pivotal was born trying to actually show whether increasing the standard ferritin, which in the UK would be about 500 micrograms per litre for a hemodialysis patient, to 700, as you heard, versus the reactive level of 200 ferritin, whether this was either harmful or better for the patients. And you can see that the primary endpoint was looking at death and cardiovascular events as well. And the iron involved in Pivotal was iron sucrose, and this involved 2,200 patients, and this is the longest trial of intravenous iron anywhere in the world, with some patients having been treated for 4.5 years plus. This is the primary outcome. You'll have seen this. It was published in 2019, and you can see that using high ferritin levels of 700 micrograms per litre, this was superior to the lower dosing, as you can see. And more particularly, if we look at cardiovascular events, and remember what I said before about this theory of reactive oxygen species being released to repeated dosing with iron, particularly, for example, with iron sucrose on dialysis, we can be reassured that actually the higher ferritin levels were associated definitely with lower MI and lower hospitalization for heart failure, significantly so. And what about that infection risk? Well, again, a subsequent publication in JASON showed any infection, hospitalization for infection, death from infection, again, was null, so the hazard ratio being 1 in those patients. So, you know, with the high dose arm versus the reactive arm. So really reassuring data. So I do want to spend a little bit of time about phosphate abnormalities and hormonal perturbations with intravenous iron therapies. You'll recall that when ferric carboxymaltose, so FCM, was going for registration with the FDA, it was noted that in some of the non-CKD studies, so in patients in gynecology, there was a significant number of patients who were developing hypophosphatemia, so phosphate levels of less than 2 milligrams per DL. And in 2009, in a very tiny study, as you can see, of just 8 patients, it was purported that maybe FGF23 was one of the precipitants of this problem. More of that in a second. So as a result, over the years, there's been 2 studies called PHOSPHARE IDA standing for iron deficiency anemia, and many of you will know of Miles Wolfe, who is based in Duke, North Carolina, who's really probably one of the leading experts on FGF23 in the world. But anyway, in the PHOSPHARE IDA trials, ferric carboxymaltose was compared with iron isomaltoside or monoferric, and you can see the data here. If we look to the left, at any time post-infusion, 74% of patients receiving ferric carboxymaltose had a phosphate of less than 2 milligrams per DL, but it was only 8% in patients receiving monoferric. And you can see the time course. So this peaked at day 14 and continued with serious hypophosphatemia out to beyond 5 weeks in many of the patients, as you can see. Also, notice that about 11 patients got serious, very serious hypophosphatemia with ferric carboxymaltose of less than 1 milligram per DL, which is, you know, very worrying. Now, how does this come about? Well, it's recognized that FGF23, which is a hormone, of course, that we release from osteocytes in bone and which primarily functions in our body to prevent the reabsorption of phosphate, and hence we don't typically see hyperphosphatemia in CKD until we get down to GFRs in the low 20s, do we? And that's because of the effects of increasing levels of FGF23 as CKD progresses. But unfortunately, FGF23 has other interactions. Not only does it drive phosphate excretion, but it also inhibits the production of activated vitamin D. So 1,25-hydroxy dihydroxy vitamin D being converted from 25-hydroxy D. That leads to hypocalcemia, and also that's a strong stimulus for secondary hyperparathyroidism. And you can see to the top right here, serious hypophosphatemia can be associated with weakness, fatigue, and in extreme cases, respiratory depression. And in people who get repeated hypophosphatemic episodes, typically in GI, then we are at risk of seeing osteomalacia. So looking at the hormone changes, we can see that intact FGF23 increases with ferric carboxymaltose, but not with monoferric. We can see that there's an increased phosphate excretion and a reduced serum phosphate, all demonstrated here. But in addition, reduced vitamin D, reduced ionized calcium, and also increased PTH, which persists for several weeks. And is this a worry for kidney patients? Big question. We, of course, are used to dealing with patients with hyperphosphatemia. Well, there's data from the US RDS. You might be familiar with this. I know it's 15 years old. This is looking at FGF23 in the US dialysis population and dividing them into quartiles according to their level of FGF23. And you can see that the patients with the highest quartiles had something like 6 times the increased risk of mortality compared to those in the lowest quartile. And some very neat lab work in mice has shown also why we might be concerned in terms of cardiovascular risk. And just if you look along the middle here, these are mice hearts in cross-section. These are the mice that have had vehicle introduced into the heart with no increase in hypertrophy at 7 and 14 days. These had FGF23 injected, and there's marked hypertrophy as soon as 7 days. And also a study from the CRIC, you probably know, the chronic renal insufficiency cohort in the United States, took 1,000 patients, looked at their echocardiographic LVH, and showed that LVH co-associated with higher levels of FGF23 as well. So there is a point there about concerns with this.
So can we request you, sir, to give us some concluding remarks so that we end on time?
You'd like me to finish?
Summarize, yeah.
Okay, right, I'll go to this slide then. Okay, so why would we want to choose monoferric instead of other intravenous ions? A few really, this is the concluding points really. First of all, there are several generic iron isomaltoside preparations available in the Indian market. There's a high likelihood of reactions with these, particularly the free iron reactions, because of the limited quality assurance governance. Now, with monoferric, you can be sure it's a high quality product. There's a minimal risk of serious hypophosphatemia with this, and even though there are limited concerns regarding phosphate in our CKD patients, hyperphosphatemia, FGF23 may well be one of the factors that leads to increased cardiovascular toxicity in our patients. We know that patients on dialysis, for example, have a very, very high rate of cardiovascular mortality. We've seen from the registration trials, so the FAIR-1 trials in the United States, that the drug is safe, monoferric is safe compared to iron sucrose. And importantly, there's no upper limit on dose. You can use 20 milligrams per kilogram. So that means if you've got a 100 kilogram patient, they can have 2 grams in sort of 60 minutes, basically. You're allowed to do that. So it's a perfect drug for use in non-dialysis CKD, in kidney transplants, in peritoneal dialysis transplants, where you can give all the iron that the patient will need in 9 to 12 months in one dose, in 1 hour, and saving staff resources. And it might also be something to consider in your hemodialysis patients. You could actually, and we do this with our home dialysis population, we bring them in, we give them a total dose infusion in one dialysis session at the hospital, and then that gives them enough iron for the next 6 months plus, and we don't have to worry about the risks of dosing iron at home. So really, if you'd like me to stop there, I'm very happy to.
So we have chairpersons who would want to give their comments, and if there are any questions, and then we promise to break for lunch immediately after this session and assemble again at 2:30, so that we leave the conference at 5 p.m. as was planned, so that there is no delay in the overall conducting of the conference. Yeah, comments from the chair.
At the outset, on behalf of all the chairmen, I would like to thank Mumbai Kidney Foundation and Umesh Khanna for coming, for inviting all of us here. Cheers to Dr. Professor Philip Kalra, and welcome back to India. My comments are only three. One is that, will you give any iron preparation at night to any patient who's in the hospital? And second is, has anyone gone above 1 gram? Have you tried to give 1,500 milligram as an infusion? And third comment, I would like to know from the audience also, that unfortunately neither ferric carboxymaltose or iron isomaltose is available in government hospitals where I work. So it's only the iron sucrose that is available. So that's a little bit of a problem for us.
I think,
so third question, I think they will answer.
Third question for the audience. Yes, I get that. So basically, the second question, the answer is absolutely. We typically give always 20 milligrams per kilogram, and we've dosed many patients to 2 grams or more. We've got some big people in the UK, so that's 100 kilograms plus. Typically we're giving doses of 1.5 grams in 45 minutes with monoferric. We are. Okay. In terms of the first question, that was at nighttime dosing of iron. We do have 3 dialysis shifts typically in my hospital, and the evening shift starts around about 7 o'clock. So they would be getting the iron in the last hour of dialysis, just as they're coming off. They would typically get iron sucrose, but they get it at that time. So it could be 11 o'clock at night, which we will have finished the meeting, by the way, before then. Right.
Yeah. One question about the dilution and the infusion time. It is said that if we infuse it as a bolus or as a fast infusion, 20-30 minutes, then the chances of free iron toxicity are less. So,
okay. So no, that's a really good point. So this is true of, I would think, of the generic irons, definitely. I think with monoferric, 2 things really. Firstly, the volume that it should be mixed up in should be kept reduced. So typically we use 100 mils of saline for maybe a gram. You can go up to 500 mils, but no more. Believe it or not, the more dilute the solution, the more chance there is of instability of the iron and greater release of free iron, believe it or not, in that. So, but in terms of speed, the fastest we would ever give a gram is 30 minutes. It's safe at that level, and that with monoferric it shouldn't provoke too many free iron reactions. Thank you.
Thank you for your talk, Dr. Philip. My question is, I'm always hesitant to give IV iron in a patient with an acute infection.
Yes.
Particularly serious infections, life-threatening infections. What is your approach in giving infection?
No, absolutely. So though I've showed you the data, particularly from Pivotal, that that we saw no signal of worries with infections there. What we would never do is recommend giving an infusion with a patient who, say, is in hospital with an active pneumonia or, say, cellulitis, osteomyelitis, something like this, active TB. I mean, it's just not the right time to give it, is it, at all? So we would avoid it at that time, give it at a later stage when the patient is better.
So you showed us the data about phosphate handling comparison between FCM and isomaltoside. Were all those patients having some form of CKD, or there was?
No, thank you very much indeed. Sorry. So I was speeding up at that point. So that was that was phosphate IDA, so it was iron deficiency anemia of other causes. So it was gastroenterology and gynecology, basically. I think that's the same study has not really been done in CKD.
So is there any experience, published or unpublished, with patients who are on dialysis or have some grade of chronic kidney disease?
There certainly is with monopheric. I was going to just champion India here because two studies. One I was the lead on. Progress was undertaken here. That was a non-dialysis CKD study, but there was also the proposed study, again involving Indian patients. My colleague Sunil Bandari was the first author, where we were testing monopheric in hemodialysis patients as well. So, it's well tolerated in dialysis. But in terms of, are you asking a comparison with ferric carboxymaltose in terms of phosphate?
So do you expect similar degree of hypophosphatemia or rise in FGF23 in patients with renal insufficiency?
So we not hypophosphatemia. I don't think we would be worried about our patients going to the ITU with phosphates of 1 milligram per DL in our CKD population, but it's this theoretical concern that we're pushing up the FGF23. It undoubtedly is one of the multifactorial problems leading to the cardiovascular disease. I've not seen any data from dialysis patients, though, to be fair.